Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussions surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations.
Good afternoon, Rebecca. I hope that you're doing well there in the really Midwest.
And yeah, doing well. Enjoying the last little bit of, our somewhat summer-like, / fall weather here. So
yes, and the leaves are turning. Well, I have a case for you that I will start us off with, if that's okay.
Sounds great.
All right. So the first case that we have is a 66-year-old who came into our hospital who was actually transferred from an outside hospital to us. He ended up at the outside hospital where he went after he fell out of bed and hit his head on his oxygen tank. So this is a gentleman who has a history of coronary artery disease, COPD, hence the 3 liters of oxygen he uses. He's at an NSTEMI. He has atrial fibrillation and is on anticoagulation with Eliquis. His hypertension, and he has an alcohol use history. So at the outside hospital, he came in and he had an ocular trauma from hitting his face, specifically his eye. And I just want to go ahead and show you what we see. All right, can you see this picture of the injury?
Wow. Yeah.
Okay. So he was at the outside hospital. They were very concerned because his right eye had a lateral interior lid margin and a right medial inferior lid margin cut, as well as injury to the punctum. And they were worried about a globe injury. So they got a CT of the face. And when they did, they were concerned for a retrobulbar hematoma and also a subcutaneous hematoma. So let's stop that.
Okay.
And get back to my description. So they started him immediately on some Ansef for antibiotic coverage for anything that could have infected this injury. And they called us to assume the patient in care because they felt like it was a higher level of injury than what their surgeons would be comfortable dealing with, being the location and what they saw. So they sent him to us. At the time that he got to us, he was hypokalemic. We replaced that. Gave him made sure his Ansef was going. We got an EKG, which showed atrial fibrillation with a heart rate over 140. And he was started on a diltiazem drip. And the ophthalmologist came immediately to look at the trauma and the injury. And they felt that there was injury to the medial canthal ligament that was involving the punctum, which they had thought at the outside hospital. So they actually gave him some conscious sedation and did some repair work in our ED. After he got started on the DILT drip, his heart rate came down to 117. He got a liter of IV fluid, and he got some Ativan because there was concern about withdrawal symptoms, and he was started on our MAWS, which is our alcohol withdrawal protocol. His still drip was continued, and because you can imagine that was a very painful injury, he was given IV morphine, several doses. And he was also then started on an attempt to start metoprolol, but he actually had the DILT drip for a 24-hour time period. They checked a BNP, and it was elevated at 364, and he had some anemia with his hemoglobin being 8. So we elected to, of course, admit him for monitoring. And one of the reasons for this admission we felt strongly about was he was on oral anticoagulation, had taken it that morning. And we were worried about that retrobulbar hematoma expansion, as well as the actual site of the repair. He stayed with us over that first midnight. And on the second day, he continued on our alcohol withdrawal MAWS program and required 4 milligrams of Ativan through the day and then 2 milligrams of Ativan over that evening. We were able to wean off his diltiazem drip when his metoprolol became more effective. He really didn't have much of a midnight, an appetite, which isn't unexpected. And he did have some anxiety. We did the regular thiamine, multivitamin, got a social work consult. And then he had a minor elevation of creatinine up to 1.44, for which he got another liter of fluid on this second day. And then his eye treatment involved erythromycin that was applied on a Q4-hour basis, initially by nursing, but then the patient was taught how to do it on his own. He again got morphine doses, IV for pain, and stayed that second midnight into the third day. On the third day, his hemoglobin was 7, but he had received a good volume of fluid over that time, and we felt it was probably consistent with a dilutional effect. And his IV morphine was switched over to PO opioids. So we sent this chart in. This is a Medicare Advantage patient, and the payer denied the stay. So I'll tell you what my arguments were for the payer, which I think you can probably figure out what they were. That we have an eye trauma here that was significant, that involved pain and required ophthalmologic intervention, conscious sedation, including fentanyl, acetaminophen. He required multiple doses of IV morphine for pain. We also worried about him being beta adrenergic because of withdrawal from alcohol that was contributing to his AFib with RVR that required 24 hours of a diltiazem drip and then conversion to a PO beta blocker. We also checked our interqual data, and he met for admission as an inpatient initially. So overall, multiple doses of Ativan, multiple doses of IV morphine, follow-up and laboratory studies to monitor his hemoglobin, and the Ativan he got, as well as I mentioned the diltiazem drip. So I'm going to turn to you, Rebecca, to say, I was kind of shocked that they denied this case. What's your thinking on it?
Well, I mean, I don't know what all the payers can see. I do know, to give them benefit of the doubt, I do know that sometimes they're given these cases very early with limited information. So possible they might have just gotten, eye injury and AFib RVR or something like that. And, and maybe they're just assuming, that should be a short stay, especially if they did some of that repair in the ED. So that's probably, again, if I'm pretending I'm the payer here, I'm thinking, it's probably not that big of an eye injury. If they could repair it in the ED, didn't have to go to the OR and have this big thing going on, and AFib by itself is usually not too exciting. So I'm assuming that's probably why the payer's like, this probably wasn't. And then, as I think we've discussed on this before, we, I think are all saying we've got plenty of cases out there that have 2 midnights worth of a hospital stay. But where we're having trouble is really proving that second midnight was medically necessary. So even if they had a little bit more information, I could see the payer, especially, you've got an alcoholic, and maybe they're saying maybe they didn't need that IV pain meds. Why, what they might have gotten it because they were here in the hospital. Did they really need it? And so I think, especially a little eye injury, like what, I'm sure they didn't have those pictures to see like we did here. Because that was a pretty impressive eye injury, or at least to me it was. And, so I suspect that's the gap for the payer. And I think, you on the PA are going to have to fill in those gaps and make the case like, why was this more than a little eye injury? And did they really need some of those IV interventions that you guys ended up providing. So how did it go? Were you able to convince them, or was it a hard conversation?
I argued this case a week after the patient was discharged. So the payer had full knowledge of everything that had transpired. And I think my big points here were the eye injury, and I actually was able to show the payer the pictures. I think is an advantage. It typically is for me. In this case, I can let the cat out of the bag. They would not reverse the denial. But I look at that and I hear retrobulbar hematoma in a patient on anticoagulation, and I think at the very least, that patient had to be monitored for at least a 48-hour period to be sure that that hematoma wasn't going to expand and we weren't going to have, because the risk here is blindness. I mean, we're not talking about a small risk possibility, a risk potential here. The other things that drove me were, the AFib with RVR, sure, we usually think if that's a single event and you're taking care of it, you should mostly be able to take care of that after the one midnight stay and convert them over to PO and get everything going the second day. But we had that in combination with alcohol withdrawal requiring treatment with benzodiazepines that were given in multiple doses. So in combination, I think we had three driving points here: the eye injury and treatment and pain with it. And I also tried to stress to the payer, the patient was taken care of in our emergency department. That's because we have an emergency department that can handle 100 patients and practically has OR and other hospital level of service and care in the trauma bays. So it's not like, the location is as important as the functionality. I think the second issue is that alcohol withdrawal. And the third issue is the AFib with RVR and getting that under control being a more minor component of it. In any case, they told me, no, you're denied, and we're leaving it denied. So needless to say, we're appealing this and writing all the letters and doing all the further escalation that will be necessary on the case.
Yeah, and I agree with you, Teresa. I think this had clear medical necessity for that second midnight. I don't think it was. And it wasn't just like, oh, well, we're worried that maybe they'll have a hematoma, which I think is a legitimate concern. But you also had all those other things we've just talked about on top of it. It's what I call the potpourri case, where you've got a little bit of this, a little bit of that, all together. And that is a much different patient than just, a perfectly healthy, let's say 20-year-old that's coming in. Well, they probably don't have Medicare, but let's say perfectly healthy, Medicare younger patient, and they, and you were just watching. I think those are really hard cases to get overturned and prove the medical necessity. But I think you had all these other things. So I definitely would have done the same thing with my team. And then you have that anemia. Like this, it could have been esophageal variceal bleed. Who knows? It had so much potential for a lot of different diagnoses that I think you were absolutely justified in keeping him the second midnight.
I think it would have been medical malpractice to not keep him. And these are one of those cases, I know you have them too, Rebecca, where you think, once the payer sees this and hears all of these things, they're going to overturn this denial. The fact that they didn't was kind of actually stunning to me. Sometimes they don't overturn the denial, and I feel like perhaps I didn't do enough of a review or have enough compelling arguments. And then I remind myself that I have to give myself some grace in those cases. On this one, I was really just quite shocked about the outcome of the peer-to-peer. But they get to decide, right?
Yeah. I've definitely seen similar cases. So
the Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. APPLCOM is inclusive of all practice settings. Membership in APPLCOM also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, APPLCOM membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org www.cmhfa.org/membership to learn more. Let's continue with our next case.
Well, I have a case for you as well. Let me get it pulled up here to refresh my memory and all the little details. So the case I have for you today, actually, it got sent to me by one of my other physician advisors who, it was a retrospective case that was sent to them, and they weren't sure they were going to bother doing the peer-to-peer on this one. And they wanted, before they just simply sent it for, a post-discharge rebill for an outpatient level of care, they wanted me to just take a second look at it. So this is a patient, it's a commercial, and the overall length of stay ended up, the patient was discharged on hospital day 3, total of 54 hours in the hospital. And it was a 64-year-old patient, had history of AFib, was on Eliquis, some moderate mitral valve regurgitation, heart failure with reduced EF. And they were coming in for a planned admission for TICUS and drug loading. And they had symptomatic atrial fibrillation. And for these, we send these cases, typically we run them through our authorization team. And with this particular payer, they had indicated that no particular authorization was needed before they came in the hospital. The team had indicated to the hospital they wanted an inpatient level of care. And that's for our bed planning purposes. So when the patient came, they did place him in inpatient. That first hospital day, patient was started on the Ticasin at 500 milligrams twice daily, baseline QTC of 403 milliseconds. So then they kept getting the ongoing EKGs after the first dose. It did bump up to 467. And then they gave that second dose on hospital day 1, and it went up to 487. Then hospital day 2, they opted, because of the QT prolongation, they wanted to reduce the Ticasin dose to 250 twice a day. And then on hospital day 3, they were still in the AFib, even after the 5th dose. And the EP physician opted to do a cardioversion, and the guy was on Eliquis, and they continued to monitor the QTC. It remained stable. And the patient was doing okay, ultimately went home, like I said, on that hospital day 3. So my PA was, his thought process was that this particular case, we did not have an inpatient auth. Sometimes we will get inpatient authorizations from the payer for these drug loading cases. We didn't have that from the payer. Patient had done relatively well, no major complications, relatively short stay. And so he did not think there was a good chance of going after that peer-to-peer. So I'm going to pause there and just say, what would your third opinion, second opinion be if it got sent to you by one of your PAs about doing a peer-to-peer?
I'll tell you what, on these cases, it really is, it's too bad if you don't get that pre-authorization for the inpatient, because, if you had that up front, it wouldn't become an issue. But
yeah,
frequently we're being told, no, you admit as OIB, outpatient in a bed, and then we'll see how it goes before we give you the inpatient. But on these cases where you're administering these cardiac meds, the patients have a monitoring, frequent EKGs. There is an intensity of services provided here that in my mind is tantamount to an inpatient level of care. And even though you didn't have a major complication here, you did have the hint that there was the potential for a complication coming when the QTC was prolonged each of the 2 doses. And I know the patient ultimately ended up having cardioversion, but I think I still would have pushed for the peer-to-peer, just to make sure that I was clear in the understanding with the payer about what they would think about administration of medications like this. They're requiring such an intensity of service, and see if maybe they too wouldn't come along with that kind of thinking. I probably would have done the peer-to-peer.
Yeah, and I totally got where my PA was coming from, and I agree. It is kind of a mixed bag for us right now. We are, like I said, still getting some payers prior authing these, some of them not really authing anything inpatient for that's planned, and just saying, well, we need to see how it plays out, then we'll consider giving you inpatient authorization. And then we've got these other cases, where they're kind of just there's like this one, they didn't require an auth for this type of admission. So there was not much we could do to get it, a yay or a nay on it. But this one, it wasn't just a 24-hour stay. So I felt like, it had the 48 hours. It wasn't just a simple drug load where they got the meds and all was well. They had the QT prolongation, needed to change the dose, and ultimately did a cardioversion. So in my mind, it had a couple more elements that made, for me, rise to the level of like, I think we have maybe a reasonable chance of getting it overturned. Not a slam dunk, but a reasonable chance. And so we did go for it. I did pull up the pay or the criteria used by this particular payer, and it was an MCG payer. So we looked at that. And actually, if you look at the criteria, it did check a lot of the boxes for inpatient level of care. And that's where I think, I think if you've been doing this for a while, I know I oftentimes am a little bit lax about going to the criteria and refreshing my memory and all the little nuances. But I think when it meets those criteria, it oftentimes can take you from a little bit of a gray case to that slam dunk. If you can say, because if they say they follow interqual or MCG and you have a case that meets it, it becomes a lot harder for them to push back and say it doesn't, they're not going to give you that inpatient level of care. So we were able to be successful with this one. And I think it was, again, wasn't sure, but I thought it was at least a worthwhile one. And I think that's, for me, has been a good message to deliver to my team as well. It's like, what do we have to lose here? Like, try to do the peer-to-peer. I mean, don't waste your time on something that was like a, absolutely an outpatient case, super short stay, nothing there. Because, it's a waste of our time. And you also, I think with that rapport you get with your payers, you don't want to take them a bunch of what I call the junk cases. They need to respect when you're talking to them, you have a legitimate case to bring to them. So I think it's always that balance. But at the same time, you don't want to self-deny, because this would have been a case that, I don't know what the difference for in and out patient payments for us, but it's definitely several $1,000 swing on this one, by getting it inpatient.
Yeah, and as I think I mentioned in the last case, the eye case I gave you, it had met interqual criteria coming in the door, which you think,
that's right.
Contractually, why would you deny something that's meeting the criteria that you say you are going to agree with us to use? But you make a really good point of looking up those criteria when it comes to the gray cases that might help push your case even further. So I'm glad to hear that you won on this case. I think it's legitimately something that required a hospital stay with the kind of intensity of services that could meet an inpatient criteria. So that renewed my faith in the system after my first case tore it apart, essentially.
Yeah, so I had to balance it out a little bit there. So we all feel a little bit better now.
Exactly. In our next session, I'm going to bring you a case where kind of the opposite is true. You think, I just don't think this case is really going to merit the argument, but then you in the end get that denial overturned, and that's a good feeling because you feel like you did the right thing and that your head is in the right direction. So,
well,
thank you
for hearing about that the next time we meet. So thanks.
Great. Thank you, Rebecca.
Okay, bye.
Bye.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Sabir, Singh, and Jacobs for sharing these interesting cases in these episodes. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.